Thank you very much. Assalamu alaikum. It's a pleasure to be virtually at the SOHO Saudi Arabia meeting, and inshallah next year we'll be finally able to be in person. As mentioned, I think the MDS field has been undergoing change in terms of integration of molecular evaluation in diagnosis and therapy, and hopefully I'll be able to provide an overview on how to use molecular data in terms of diagnosis, prognosis, and management. Those are my conflict of interest. As you know, myelodysplastic syndrome is a neoplastic stem cell disease. It's a heterogeneous group of disorders characterized by bone marrow failure and tendency to progress to acute myeloid leukemia. Not every patient will progress to acute myeloid leukemia, around 30 to 40% will. However, unfortunately, majority of the patients will die from complications related to the disease, namely the cytopenia and their manifestations or complications. Myelodysplastic syndrome is probably the most common myeloid disease in the United States. Average age is 70, slightly more common in male. The diagnostic criteria historically or traditionally had been presence of cytopenia, and then demonstration either of dysplasia, increased myeloblasts, or a karyotype that is consistent with MDS. The WHO has certain cytogenetic abnormalities that one can make the diagnosis of myelodysplastic syndrome based on that. Obviously, there are so many other conditions that can mimic MDS. Some of them are benign, vitamin deficiencies. The classical one we always bring up is copper deficiency that can cause dysplasia and bring sideroblasts. But there are other diseases that can overlap, like large granular lymphocytic leukemia, in cases of hypoplastic MDS, aplastic anemia, and so forth. Now, we know that MDS is really a genetic disease. Nowadays, in almost 90% of the cases, we can demonstrate a mutation in patients with MDS. And the disease really is an interplay between a clone, a hematopoietic stem cell abnormal clone, and a inflammatory milieu in the bone marrow, as well as immune deregulation. Early on in the disease, the MDS clone and inflammatory milieu contributes to this accelerated apoptosis or pyroptosis that explains the cytopenia. As the disease evolves, those mutations lead to a lack of differentiation, accumulation of blast, and progression to acute myeloid leukemia. And as you know, we can look at genetic abnormalities at different levels. So we have the classical karyotype or the G banding. That's been the gold standard. It requires to do G banding for the metaphases of the cells. The sensitivity is 1 out of 20, and it's the bird view for the abnormalities. In 30 to 40% of the patients will detect abnormality in MDS. We have the FISH analysis, fluorescence in situ hybridization. Those are preset probes looking for common abnormalities, such as the ones shown here. Many places do what we call as an MDS panel. The sensitivity is higher, 1 out of 200. However, probably the utility of FISH adding to karyotype is not that much. We looked in our database, in around 3% of the patients that had normal cytogenetics, the FISH was able to add information to the regular karyotype. However, in cases where there is no mitotic activity or cytogenetics were not done, sometimes it could be helpful. And obviously, the change had been integration of next generation sequencing with the ability to detect point mutations, where nowadays we detect an abnormality in almost 80% of the patients. And as you can see here, we can lump those mutations in pathways, and it turns out that MDS is really a disease of epigenetic deregulation and splicing machinery abnormalities. So mutations like DNMT3A, TET2, SXL1, splicing mutations are very common. Obviously, TP53 is the mutation that we worry about and carries the worst outcome across all myeloid diseases, probably in general. And as part of the recognition of the molecular data, now we talk about a spectrum of the disease. So the WHO and ICC classification now recognize MDS precursor states. So we have CHIP, clonal hematopoiesis of indeterminate potential, and we have clonal cytopenia of unknown significance. and those precede the frank phase of MDS or the dysplasia on the bone marrow. CHIP is presence of somatic mutation, indicating that some of the hematopoiesis is clonal. Typically, patients will have normal blood counts, and they have one mutation. Most common are what we call them the DTA, DNMT3A, TET2, or SXL1. The variant allele frequency is typically around 10 to 20%. CCUS, patients have cytopenia, but there is not enough morphology to call MDS, no increased blasts, no dysplasia. Those patients have low blood counts that cannot be explained by any other explanation. In general, they have same number of mutations compared to MDS, and the variant allele frequency of those mutations is similar to MDS as well. Why is this important? I think for CHIP, those patients are at risk of developing heme malignancies. The risk is low in general, 0.5 to 1% probably annually, but it can be not just MDS, it can be lymphomas and myelomas as well. I think the most important part of this, that those patients with CHIP are at higher risk of accelerated atherosclerosis, and the number one cause of mortality is cardiovascular. Also, we learned that those patients that carry CHIP mutation, if they get chemotherapy for other diseases like lymphoma, solid tumors, or myeloma, are at 6 to 12 folds higher risk of developing therapy-related MDS or AML. That's something now we're starting to pay attention and weighing on that and the benefit and risk analysis of the patient receiving, for example, adjuvant chemotherapy for breast cancer. And finally, obviously, we encounter now donor-related CHIP after allogeneic stem cell transplant, and we've had cases where patients develop donor-related MDS or AML from the donor. Now, CCUS is more likely to progress to MDS. Certain mutations, or if there is more than one mutation, based on the variant allele frequency, the risk could be at almost at 80% within a couple of years. Now, moving to MDS, once we diagnose MDS, this year we had two classifications. Historically, we used to have one joint classification. There was a separation a little bit between the WHO and the ICC. There are so many similarities, but some differences in between those two classifications. And I think the most important is to stress that both classifications now are integrating molecular data into the classification. So this is the WHO. So we have unique entities, deletion 5q, which was present before, SF3B1, and the biallelic P53. And then a morphological definition, no increase in the blast, excess blast 1, 2, introducing MDS with fibrosis, and also introducing hypoplastic MDS because it can be treated differently. I think the importance is really those molecularly defined subtypes of the disease are defined now by the new classification. The ICC has some similar classification. There are differences a little bit in defining the P53 group. The major difference in the ICC classification is really that group above 10% is now called AML-MDS. There are certain cytogenetic abnormalities that are defining for AML. There are some, recurrent abnormalities that are defining for, or genetic abnormalities that are defining for MDS as well. I think the importance of this, that this will be integrated in the clinical trials and may give the option of treating those patients similar to AML. Obviously, this creates some anxiety for patients where a patient with 10% blast could be referred to as AML. At the upcoming ASH meeting this year, we'll be presenting some data from our database, looking at both of those classifications, trying to see which one is better. And I think the reality or the bottom line that both of them got some things correctly. I think there is no doubt that there are well-defined molecular entities in MDS. Again, deletion 5q, SF3B1, P53. The cutoff of the blasts where we see difference in the outcome could be variable. I look at MDS either without increased blast or once the blasts are increased. That's definitely a different disease, or what I think in my mind is an accelerated phase of the MDS heading to AML. So in addition to diagnosis, obviously, the molecular data are now integrated into the risk stratification, which is our most important step to decide how to tailor the treatment accordingly, namely deciding are those patients going to be considered for allogeneic stem cell transplant. As you well know, we've used the revised international prognostic scoring system for many years. And past year at ASH, there was a presentation about the IPSSM molecular. So this classification was based on almost 3,000 patients, where they looked at different variables, clinical as well as molecular. They retained the revised IPSS variables with the exception of the neutropenia, which was excluded, and the integrated molecular data from 17 genetic variables and additional data from one genetic variable for 15 residual genes. This tool is available online now, and one can calculate the risk score. And it also accounts for if you have missing variables, so it will give you the worst and best case scenario based on that. The strongest associations with poor outcome, as expected, were related to TP53 multi-hit, which usually could be either a variant allele frequency more than 50%, 2 mutations. Some would consider also presence of complex karyotype with P53. And if a SNP array is done where we can identify loss of heterozygosity for P53. What was not expected is discovery of this MLL-PTD abnormality in 2% of the patients that's associated with worse outcome. The current NGS platforms don't include the MLL-PTD. We're working on integrating that in the NGS platform. And finally, FLT3 that happens in a very small number of patients. But also some other mutations that are good risk, like the SF3B1, we learned that the risk varies based on the concomitant other abnormalities. So for example, deletion 5q is commonly a good prognostic cytogenetic abnormality, but SF3B1 with deletion 5q actually don't do as well. Similarly, co-occurrence of some mutations like RUNX1, NRAS with SF3B1 makes the outcome worse for those patients. At the end, if one calculates the IPSSM, we come with 6 categories now, all compared to an average risk patient. So what we consider as lower risk is probably the first 3 categories, while the ones moderate, high, and very high are considered a higher risk. In comparison to the revised IPSS, almost half of the patients are restaged. Around 10% of those patients are staged in 2 categories or more. So now this is available and being integrated in the upcoming clinical trial. And we are trying to look at the impact of treatment if we restage or reclassify patients again according to the molecular classification. So once we establish a diagnosis and risk stratify the patients, obviously the molecular information can have some role in also determining the management for those patients. And I will discuss some examples. In the lower risk MDS, obviously the deletion 5q that had been probably the most important genetic abnormality that we based treatment for, SF3B1 mutation in severe neutropenia, and then I'll touch base a little bit in the higher risk, particularly in the P53 mutation and management of P53 in higher risk MDS. So as we know, one of the most established genetic markers had been the deletion 5q in lower risk MDS. Typically, those patients are anemic, and lenalidomide had been the standard of care for those patients almost over a decade now, where 67% of the patients were transfusion dependent become transfusion independent. Responses are durable on average for 3 years, and half of the patients will achieve cytogenetic response. Our colleagues in Spain conducted this trial called the Central Rev trial. So they asked, in the context of deletion 5q, what if we introduce the lenalidomide earlier on and those patients are not transfusion dependent? So they designed this study where they took patients if they were anemic but not transfusion dependent, gave them 5 milligrams of lenalidomide. The typical dose we use in transfusion dependent patients is 10 milligrams. And they did the treatment only for 2 years. And the primary endpoint, rather than transfusion independency, was transfusion-free survival. And they were able to demonstrate that the transfusion-free survival was doubled among those patients, or tripled, around 75 or 76-month transfusion-free survival. 80% of the patients achieved cytogenetic response. So this is really kind of challenging the classical dogma of using transfusion independency at endpoint, and showing that when we have effective treatment for a molecularly targeted group, that maybe early intervention is effective. Now, as I mentioned, we reported this earlier, and the IPSSM had confirmed this. Some mutations, concomitant mutations that are good, like the deletion 5q and the SF3B1, actually carries worse outcome. Originally, there were reports about TP53 detected in around 20% of patients with deletion 5q associated with worse outcome. In our database, we were not able to show that the P53 is associated with worse outcome, and I think this has been confirmed again by other groups. However, the presence of SF3B1 deletion 5q surprisingly was associated with worse outcome and less responses to lenalidomide. Now, moving to other category where we have some molecular guided therapy are patients with MDS with ring sideroblasts. As you know, ring sideroblasts are erythroid precursors with perinuclear iron deposit because of defect in the mitochondria transporting the iron. Ring sideroblasts are not peculiar to MDS. They can be seen in hereditary sideroblastic anemia. They can be seen in copper deficiency. But 80% of those patients have association with the splicing mutation SF3B1 that typically is associated with favorable outcome, and now that is recognized as a unique entity where the blasts are less than 5%, absence of complex karyotype, absence of other concomitant mutations. One could call SF3B1 MDS subtype. And for that, we have now treatment approved, luspatercept. This is a fusion trap protein that binds the TGF beta ligands and neutralize them in the serum, namely GDF11 and other ligands that tend to regulate the terminal erythroid differentiation. So erythroid stimulating agents such as erythropoietin or darbepoetin regulate earlier erythroid differentiation, while the TGF beta ligands block the terminal erythroid differentiation. So we call those erythroid maturating agents. We tested originally a drug called sotatercept. Our colleague from Germany tested luspatercept, and then we joined force together, and luspatercept was tested in the MEDALIST trial in patients with ring sideroblasts, where 80 or 90% of those patients had this SF3B1 mutation. And that led to the approval of the luspatercept in patients that are transfusion dependent with ring sideroblasts, where around 1/3 of the patients became transfusion independent for 16 weeks or more. Finally, we've been interested in patients that have severe neutropenia. There is a small subset of MDS patients, lower risk, that present with isolated neutropenia or severe neutropenia. Typically, those patients actually do well, and I don't treat them unless they have recurrent infections. The traditional use of GCSF had not been shown to improve survival. Use of hypomethylating agents rarely leads to responses. We looked in our database and we saw that this group of patients with severe neutropenia are enriched with IDH mutations. And we treated a small subset of patients with IDH inhibitors, had a complete response in the neutrophil count that was durable. The French group, and I will discuss briefly later on, are looking at IDH inhibitors in MDS, and a cohort of those patients were lower risk, demonstrating promising responses. So this could be a potential therapy for patients with isolated neutropenia if they have the IDH mutation. Now, moving to the higher risk, as you know, allogeneic stem cell transplant remains our only curative option for those patients. But we know that the outcome for those patients is based on molecular and clinical variables, obviously myeloblast percentage at time of transplant, cytogenetic abnormalities, as well as molecular abnormalities. What evolved clearly that presence of P53 mutation is associated with worse outcome, including with transplant. So P53 mutation is present in probably around 20% of the cases, typically associated with complex karyotype. It's the strongest predictor of inferior outcome, as well as inferior outcome with transplant. This is data from Dr. Lindsley, published in New England, showing that patients with p53 mutation, whether they were young or old, had a high risk of relapse after transplant. Now, in general, we can argue that those patients do better with transplant than without transplant. But the outcomes still with transplant are dismal, where like probably 80% of the patients will relapse within a year. That poses the question, should ethically we transplant patients with p53 if they have still the mutation detected? Our group have been trying to follow the attempt of treating patients with hypomethylating agents or on clinical trials, trying to clear the p53 mutation or bring the variant allele frequency to below 10% and then take those patients to transplant. And you can see here, we just published this last year. It's a small cohort of patients, but when we were able to clear the p53 followed by transplant, this was associated with favorable outcome, while in those patients that went to transplant without clearance, they didn't look that there is much difference than treating those patients with hypomethylating agents alone. And this is also another attempt from our group looking at this differently, looking at all patients with MDS and AML that went to transplant, either clearing the p53 or with persistent of the p53, demonstrating that with clearance of the p53, we have favorable outcome. Obviously, clearing the p53 is not achievable with for every patient, and we've been trying to attempt to enroll those patients on trials to increase the chances of complete responses and molecular responses. One of the promising drugs that seems to be agonistic of mutations is magrolimab. This is a anti-CD47. CD47 is known as the don't eat me signal, so it prevents macrophages engulfing the leukemia or MDS cells. And in combination with hypomethylating agents had yielded promising responses, particularly in p53 mutant, both MDS, AML, showing promising responses, particularly for patients going to transplant. So magrolimab has finished phase 3 clinical trial, and if confirming the phase 1, phase 2 signal, hopefully it will be approved for patients with MDS AML and will help in a group of patients, particularly the p53, that typically don't have higher responses to hypomethylating agents. As you know, venetoclax is approved for AML, and we've been borrowing using it in high-risk MDS patients. But the data from Dr. DiNardo, even in AML, showed that p53 patients had higher response to venetoclax, but no overall survival advantage. So the only time we use venetoclax in AML, MDS in combination with HMA and p53 if we're going to take those patients to transplant. So this is data from our group as well, looking at a small subset of patients treated with HMA ven compared to HMA alone. I think what was remarkable, the 2-year survival with transplant is 91% versus 51% historically for HMA alone. The overall survival for the whole cohort did not look different. Again, in p53, we do see higher responses with the combination. So as a bridge to transplant, that's reasonable. And finally, among patients with SXL1 mutation, a mutation that historically we only have 8% of the patients achieving complete response with hypomethylating agents alone, we were able to increase the response rates to around 44%. There was a recent paper from Dr. Amit Verma from the Albert Einstein group showing that in SXL1 mutant patients, we have over expression of the BCL2, which seems to be mediating the resistance. So adding venetoclax will down-regulate BCL2 and explains the higher responses. Now, another area where we can integrate molecular data is at time of HMA failure. As you know, almost all patients eventually will have HMA failure. The average duration of response is around a year, year and a half. So I think it's almost important to reevaluate the disease at that time, check for molecular data. Again, the mutations detected will be probably in 5 to 10% of a group of patients, but collectively, if you add those mutations, you'll probably identify a target in around 30% of the patients, such as IDH1, IDH2, FLT3 that can happen at time of HMA failure, NPM1, sometimes even RAS mutation pathway could be targeted with off-label therapies. For the other patients without a targeted mutation, sometimes we add venetoclax at time of HMA failure. Those are trials from the French group looking at IDH1, IDH2 mutation in separate different cohorts, one of them up front with HMA, post-HMA failure and higher risk, and as I mentioned earlier, in the lower risk MDS, so showing some promising data as well. So in summary, I think integration of molecular alterations in real-world defined spectrum of myeloid diseases. So now we talk about CHIP and CCUS. We are having trials in CCUS to try to prevent the progression to MDS. Hopefully, we'll have more targeted therapies with earlier intervention in patients with MDS. The classification and risk stratification of MDS is really refined by molecular data. The new WHO ICC classifications integrate molecular data. The new risk stratification, the IPSSM, integrate molecular data there. And the treatment can be tailored based on molecular data. As we saw, there are few examples that we are currently doing. And I think the future of clinical trials will be based on tailoring therapy based on those molecular defined subsets for MDS. With that, I will stop. Thank you very much for listening. Appreciate the invitation, and I'm looking forward for the discussion session and any questions. Thank you.